Gastroesophageal reflux disease, or GERD, is a common medical problem. In this condition, the acid from the stomach backs up into the esophagus, which causes a typical symptom for the patients called heartburn. Now, many of these patients can be experiencing this pain or discomfort in the chest, which is a short duration, or it could be repetitive and for longer durations. So the condition could be mild, and some of the patients can have severe symptoms. The associated symptoms typically are the food which regurgitates back into the mouth, returns back into the mouth, and patients complain of excessive belching. And less common is patients presenting with a dry cough at night because of droplets of acid getting aspirated into the airway. Some patients do present with asthma-like symptoms. And a few patients present with dysphagia or a difficulty in swallowing. Now, when a patient presents, the history is quite typical, and one could have a presumptive diagnosis of GERD. For confirming the diagnosis, we do an endoscopy, a flexible upper GI endoscopy. The vast majority of these patients can be treated with medications. The important thing is the medications should be used for 6 to 8 weeks duration, and typically we use these proton pump inhibitors twice daily for a period of 6 to 8 weeks. Shorter duration might give immediate relief, but patients do experience frequent relapses. Now here, let's say you treat with medications 100 patients with GERD, 90% of them do very well with medications, are symptom free. They might occasionally require these medications, a repeat course of these medications in future, but 90% largely would be doing well with medications. 10% of patients are ones who experience repeat symptoms when you stop the medications. They seem to do well with the medications. When you get them off medications, they get the symptoms back. And there are some small number of patients who don't do well with medications at all. It is these patients that we evaluate further. There are tests such as 24-hour pH study. You study the acid levels in the food pipe to see during a 24-hour period the pattern of exposure of acid during swallowing, during eating food, in the rest periods, in the erect position, and when the patient is asleep. The other test is a manometry or a pressure study of the food pipe to see the type of what we call movements in the esophagus, peristaltic movements, the pattern of these movements during swallowing, the pattern of movements during rest, and then there are scores derived from this which will tell the severity of GERD. Now, based on assessment of acid study and this pressure studies, we select out patients who are not doing well with medications in terms of relapsing frequently when they get off medications for what we call the laparoscopic anti-reflux surgical procedure, a fundoplication. This is a laparoscopy operation where the patient has to stay for 1 day in the hospital. Since it's done through the keyhole approach, pain is, there's hardly any pain. The patients are up and about in 6 to 7 hours after surgery. They are discharged on the next day after surgery. And 90% of the patients after anti-reflux do not experience reflux symptoms. 10% of patients might require small doses of medications during follow-up period. The serious complications with the GERD, seen infrequently, but one could develop a stricture or a tight narrowing of the lower end of food pipe. One could develop what we call Barrett's esophagus, what is considered a pre-cancerous change in the lower end of food pipe. Actual malignancy incidence may not be that common compared to the incidence we see of this change in the lining. But once you see a change in the lining, you need to be under regular follow-up with a specialist to see, is there a progression of this change? Is there a change of this to cancer? And when under surveillance, one may detect these tumors early and offer appropriate treatment at an early stage. In patients with acid reflux disease, apart from the medications used to treat, patients need to follow certain lifestyle changes. Now there are certain clear no's: no caffeine products, no alcohol, no capsicum, no aerated beverages. And patients need to drink liquids 1 hour after a meal. And it's important for them to understand that they should recline 2 hours after a meal. So typically, if one has a dinner at 8 p.m., it's okay to recline after 10 p.m. So it's not all right to have dinner at 9:30 p.m. and sleep at 10 p.m. because the symptoms are significantly aggravated in these patients. There are specific foods which patients do not tolerate. So the physician has to specifically look into these symptoms and advise avoidance of these foodstuffs.